Good evening. I am Dr. Raveendran P. I am the HOD and Senior Consultant in Cardiology at Srichand Specialty Hospital in Kannur. So today I'll be discussing about the role of NOACS and antiplatelet agents in CVD management. As you know, atrial fibrillation is one of the most common clinically manifest arrhythmia, causing significant morbidity and mortality due to the main complication, that is the systemic thromboembolism. As age advances, the incidence of arrhythmia increases, and the atrial fibrillation is very common in some valvular heart disease and some other structural heart disease, whereas the so-called lone atrial fibrillation or the non-valvular AF is increasingly frequent in the elderly, especially people beyond the age of 65. So, for a long time, this entity was treated by different medicines, and our main aim in the treatment of atrial fibrillation is to prevent systemic thromboembolism. The other aim is to maintain a normal, stable cardiac rhythm or this stable heart rate. So there are two ways of treating the atrial fibrillation as regards to the rate or rhythm control. One is the rate control, there is the rhythm control. In the rhythm control, we want to convert the atrial fibrillation to sinus rhythm by either pharmacological or electric methods. Whereas the rate control, we give appropriate medicines like beta blockers to control the ventricular rate to around 80 to 110 so that the hemodynamics are maintained reasonably well. But the main treatment in atrial fibrillation is aimed at stroke prevention. So for a long time, the stroke prevention AF was achieved by using the vitamin K antagonists, anticoagulants. Antiplatelet agents are not very effective in prevention of stroke in atrial fibrillation. So we had to use anticoagulant, and the conventionally available anticoagulant for a long time was the vitamin K dependent anticoagulants like warfarin and acetaminophen. The problem with these drugs are the bioavailability of these drugs, the vitamin K dependent anticoagulant, is highly variable. Either it is increasingly protein bound, or the level is affected by different foods, different medicines, and some other unknown factors. So to get a steady state of the drug in the body, or to get a steady anticoagulation status, we have to monitor a clotting factor, the prothrombin time INR, at least once in a month, and titrate it to get the reasonable effect. Titrate the dose of the drug to get the reasonable effect. So we keep the INR between 2 and 3 to maintain an anticoagulation so that the stroke prevention is achieved. So because of this high variability in the blood level, patients can either develop bleeding tendency when the INR is high, or can develop systemic thromboembolism in spite of taking the medicine. So in the last few years, we have seen the advent of newer drugs that are called novel oral anticoagulants, or the non-vitamin K dependent anticoagulants, which achieve a steady level of anticoagulation with a fixed dose of the drug. So two different classes of drugs are available. One is the pyridine-like drug, the dabigatran, and the other is the factor 10 antagonist anticoagulant, the apixaban, rivaroxaban, and edoxaban. So in our country, we have dabigatran, apixaban, and rivaroxaban. So various trials have taken place comparing the efficacy of these newer drugs against warfarin. And initial studies have shown the non-inferiority of these agents, the novel anticoagulants, compared to warfarin in terms of efficacy as well as bleeding complication. But whereas some of the recent studies have shown superiority of medicines like apixaban against warfarin in achieving this antithrombotic effect as well as less bleeding tendency. The Aristotle trial showed that apixaban was not only non-inferior, but in fact superior to warfarin in preventing stroke and systemic embolism with less bleeding and reduced mortality. Consequently, the 2019 SCHA HRS guidelines for patients with atrial fibrillation recommended NOACS over warfarin in NOAC eligible patients with atrial fibrillation. Then, regarding antiplatelet agent in cardiovascular disease prevention or cardiovascular disease treatment, in any patient who had an acute coronary syndrome or patient who had coronary interventions like angioplasty or bypass surgery, the initial 1 year, there's a increased risk of recurrent events. So to combat this, we have to use two two different antiplatelet agents. And one, in fact, it is aspirin. The second is from a class of drug called P2Y12 receptor antagonist. For a long time, we had clopidogrel as the agent, other than or in combination with aspirin as a second drug for the antithrombotic effect or preventing recurrent events. Especially for this is more relevant in patients who undergo angioplasty. The issue with clopidogrel was that, in spite of giving a loading dose of clopidogrel and maintaining the dose, the issue of acute and subacute stent thrombosis was on the higher side. Clopidogrel is a prodrug with a short-lived active metabolite and had mild potency, slow onset of action, and a large inter-individual variability in its biological effects. Even if you give a loading dose, it may take 1 to 2 hours for a reasonable level of the drug to be achieved in the blood. So till that time, there is a risk of acute stent thrombosis. And also in the maintenance phase also, it is not a very potent drug. So the incidence of subacute stent thrombosis was there. But because the newer drug in that group, that's ticagrelor and prasugrel, they achieve a faster blood level even within less than 1 hour, and they are more potent in action, and the incidence of stent thrombosis and other complications are much less with the use of drugs like ticagrelor. Ticagrelor is not a prodrug; it doesn't require any biotransmission to be effective, and has a significant shorter delay of action, requiring only 1 hour to achieve maximum platelet activity inhibition compared to 6 to 12 hours for clopidogrel in stable patients. The all-cause mortality benefit observed with ticagrelor in the plateau trial and the side effect prompted the hypothesis of pleiotropic effects of ticagrelor beyond its antiplatelet effect. Most notably, these benefits of ticagrelor is independent of the therapeutic strategy chosen, medical, invasive, or surgical. So, because of this, these two new drugs like apixaban, which is a novel anticoagulant, and ticagrelor, a novel antiplatelet agent, has made a significant role in preventing recurrent events in cardiovascular disease. The NOACS in stroke prevention atrial fibrillation, and ticagrelor in the incidence of stent thrombosis following percutaneous coronary interventions. Thank you.